All right, let me just shift. So there you are, Prof. Uh, you able to see the slides?
Doctor, we can see the slides, yes?
All right, thank you so much. Please carry on.
Good afternoon, colleagues. We thought that we have a short discussion this afternoon on continuity of HIV services, but also included in here TB, malaria, and other related infections which are managed in the public sector. We, I think, now know of what has been transpiring from the United States, which is a major supporter of our HIV service delivery, but also TB and malaria, besides many other services which are provided in the country. We know of the executive order, and afterwards we also received the details of the waivers on foreign assistance force, and we now have clarity on what our colleagues from the US government are able to support. And what they are not able to support.
Prof, I think we may be having network challenges. Perhaps you could just put out your video. Maybe that might help with the network. I don't know if you can hear us. We lost you for a bit, Dr. Prof.
Thank you, thank you. So on 30th January, we issued a memo from the Office of the Permanent Secretary Donor Coordination, emphasizing the fact that services needed to continue and that there was engagement which was going on with PEPFAR. And also, we have had a detailed interpretation of what was contained in the January waiver. And on February 11th, we received again some communication of termination, the rescinding of the termination of and cessation, suspension, or also any of those activities limited under the PEPFAR awards. Now, again, this is just in the interim as various processes are going on in the US government. So we thought that it would be good to guide the service providers bearing in mind that we have a lot of input. The next slide from our partners from USAID, from CDC, and also from the Department of Defense, the Peace Corps, and also the Department of State itself, which is PEPFAR. And we have certain service deliveries areas which were affected. And we just wanted to touch base with you on how we are proceeding. We have a total of 2,885 facilities which are providing HIV services. And of those, we also have the faith-based facilities, and also we have the private facilities. The faith-based and private facilities, they are catering for 164,344 recipients of care. And the work which is being done right now, it has continued, especially provision of ART services, but there are variations in scope. We are updated, and hopefully that by tomorrow, some of you will also be updating us on a weekly basis, because there is a tool which we want you to be filling for us to know which services are opening up and which ones are not opening up. I wanted also to look at, from our minimum package of service delivery, what gaps do we have? Next slide. We can assure your service providers that in terms of the ARVs for first line, we have enough, which is able to take us up to the end of the year. We have about 7 months of stock, and we also have other stocks which are expected, with commitments from the Zambian government, from the Global Fund. And also we have some shipments which are on the way, supported by the US government. So again, this is not a time to panic. It's time to really make sure that we provide our services well. We have heard of a possibility of a danger in that some healthcare workers may start charging some recipients of care for them to receive enough commodities. We should not sell any of the drugs. The drugs which we have available are adequate for our close to 1.3 million people living with HIV, and they are according to how we quantified for, and there shouldn't be any panic in terms of provision of the ARVs. We also have adequate stock for the prevention commodities, and also that includes the PMTCT as well. So really there is no need to panic and ask people to come and get for 12 months and give them money, let them give the healthcare workers money. This is an important point which we needed to labor on. We have inadequate commodities, and we are also putting mechanisms of receiving some of those commodities earlier, so that we do not end the year with zero stock. But for this current year, we have enough commodities, and we are putting in mechanisms to make sure that we have enough stock getting into the coming year. The next slide, Dr. Ziambo, highlights some of the key commitments which we have made as a country, and which we continue committing to. We will continue providing prevention services. We'll continue providing oral PrEP, and we'll also continue providing injectable PrEP as well. So the way the services we are running, we'll continue providing those services. We may have adjustments in what modalities that we may have, but all those commodities which we really planned for prevention and also for treatment, they are available. And we are also on course to making sure that we also bring in the 6-monthly lenacapavir. I need to say that we may have some adjustments over the dapivirine vaginal ring. We may have some conversations looking at, is it a priority for now, looking at where we are. and there will be a package which will be shared possibly within the next 2 weeks, as highlighted in the memo sent yesterday, which I think many of you should have. We emphasize on the role for DVR. So this is one commodity which may be affected, but for the injectable PrEP, oral, any breakage or interruption in service delivery around the prevention aspects. Next slide, Doctor, we're looking at the challenges and also some of the mitigation measures. We have had, of course, issues to do with the HIV test kits. We have put in mechanisms to make sure that we receive enough commodities for the HIV test kits. When we look at the package for the minimum service delivery, you may see that some of the things and at policy level, viral load reagents, TB expert cartridges, these were in smaller quantities, and we are making sure that they come on with GRZ, with PEPFAR, where those which are on the way, and also with the Global Fund as well. Human resource is also a challenge. We see that there have been areas where the partners withdrew the HRS, and we are working to make sure that in the long term we are able to provide even the HRS support, making sure that some of the support which is under PEPFAR goes into GRZ, and there is high engagement on how this may be done. It may not be all, but there's serious consideration. The past 3 days, we've just been concentrating on what we can do to make sure that government at large takes up some of the pieces which may not be available with PEPFAR not being available. That is in an instance where we do not have PEPFAR funding, but so far we are confident of the engagements which have been happening, but we have to make sure that any gaps that may be filled in the interim and also in the future as part of the sustainability, we have government taking up more of the HR staff. We also noticed that there's been disruption in the sample courier. I know that this week is very crucial because this is the week some of the partners may start coming back to provide some of these services in the courier, and we are sure that possibly by next week many things may start opening up in a gradual manner. But as government as well, there are other short-term measures which are being put in place to make sure that moving forward, we also have a backup for courier services as well. So the quantification is being done, looking at the budgets and where can we leverage on resources, including resources from other partners to make sure that we have minimal disruption of those services. The next slide. The lab information systems as well. We've been looking at how we can get some of the licenses supported for under government, but also the circular which was sent yesterday referring to the fact that whenever, should we have any interruption of services, any withdrawal as well of funding, we will need to make sure that we do handover in a right way so that we don't have interruption of services to an extent like we had in the past a few weeks, which led to some of the data issues not being attended to. And we have comprehensively looked at and try to see which pieces can be taken up by government, by Global Fund. But PEPFAR still having a huge role to play, even in the future, over monitoring over the information systems, and also making sure that we have up-to-date activities centered around the M&Es. The next slide. So we have these wellness centers. I'm sure the communities have been trying to see what is the future for these wellness centers. There will be certain services which will be opened up, but we are looking also at mechanisms of making sure that these wellness centers, they have a higher support from the mother facilities, and having the public health nurses try to man these wellness centers. We realize that we still need to have services in the community, and where we need to leverage on CDF support, that has to be done. And the services have to be for around testing, prevention, but also treatment to a certain extent according to what is available. So not everything which is provided in the wellness centers when the minimum package comes in will be provided. It has to be what government will be able to afford. Next slide. So our immediate needs are redeployment of healthcare workers, stabilizing of the commodity supply chain, and I'm glad that first around the lab where we had some issues for commodities, and this includes also the antimalarials as well, and also the TB cartridges for us to be able to diagnose TB rightly as well. We're trying to stabilize that aspect. And those challenges which we are having, they're independent of the freezing of the aid. They are challenges which were just there in the supply chain, and we're trying to, with ZAMSA, make sure that we iron out those small issues which are affecting the commodity security. Next slide. We, as I earlier said as well, in the immediate, we are having a stabilization of the courier services as well, and also the health information systems. We are glad that some of the areas in the northern region, we are also have the government health workers who have picked up data entry, and we are also looking at the long-term future of how this data entry can be moved to the government-employed health workers. So time when we have the donor support, PEPFAR and others, it's time for us to help build capacity and to move fast in the transition to the sustainable HIV service delivery. The next slide looks at the medium-term recommendations, which we have. Next slide, where we are looking at how can we make sure that the pharmacy and lab commodities are secure with the promotion of local manufacturing, and also how do we make sure that ARVs and TB drugs are part of the insurance under NEMA, but also we are looking at how do we help transition some of the recipients of care who are receiving drug and cut off, so that those that are able to afford the 150,000 kwacha per month to buy the ARVs, they should be able to buy, and the private sector should be able to pick up that. That is part of the sustainable way. The human resource for health is, again, as we alluded to, where we can have some staff looking at how we can increase the commodity distribution and courier, including the use of ZAMPOST as well. The next slide. So in summary, we have around 7 broad areas for sustainability: creating a health fund and strengthening the national health insurance and policy adjustments, looking at increasing the national budget allocation for HIV services. We know that this is big. There are constraints which we have around date, climate change as well. So we know that we are in a constrained fiscal space, and all these engagements are building environment for us to provide services for all and building a resilient health system for health and private sector participation, which is very key for a sustainable HIV service delivery. Dr. Kozia, I think that should be the slide, the end of the slide deck.
Thank you so much, Prof, for this very important message that you've been able to deliver to the people out there. We appreciate everyone who has connected. We have hit numbers like 150. We can understand how important this session was. So I will ask and invite, Prof, how many more minutes do you have with us? I know you should be moving out very soon. How much time are you giving us?
Sorry, I'd received a call. So Dr. Kozia, I can pick up a number of questions. I think it's better to hear from people. But I also needed to highlight the memo which was sent yesterday highlights the fact that we need to provide HIV services to all people. Right now, there are no restrictions. The way we used to provide services before is how we are providing services after there was the rescinding of the decision for the stop work order and also those restrictions. But even beyond, we don't know what is going to happen after the 90 days of the USG reviews. If there will be more restrictions, as government, we are prepared to take up the HIV services, but they will not be provided in the same manner and similar intensity as provided before. And that's why the minimum package will come in. So it's a fluid environment we are in. Things are changing, but we are committed to making sure that the basic or a minimum package is implemented with support, of course, from donors, and where there are limitations, government to take up a number of pieces, but we need the private sector as well to come in. So really, HIV treatment services, they need to continue. HIV prevention services, they need to continue as well. We need to continue the HIV testing. We need to make sure that we also invest heavily, especially this time, in capacity building. We may not now go to be having meetings, conferences. Now it's time to help build capacity through the virtual systems and also on-site where those highly skilled workers can impart knowledge in the lower cadres as well. This is also a time when we expect our partners to help in building capacities. As technical assistance partners, I think it's time to fast track moving this capacity to the healthcare workers who are routine or ideally stationed and providing the care strategically in these various sites that we have. So I would like to hear more from the service providers for any questions before I leave Dr. Ziambo. Thank you.
Thank you so much, Prof. Network, you are free to raise your hand and then we can allow you to speak. So just put up your hands and then we'll allow you to speak. So do we have any questions? So from the chat, I think has been quite, the chat has been busy, but I'm aware that our supply chain team has been answering most of those questions, those concerns and the questions. So I think there are all the questions on the chat regarding the commodities, and Mr. Kampamba and Ms. Rachel also have been able to respond to those, so we'll not go there. I think there's some questions here. Any plans for the healthcare worker in the affected by IPs? I think that's another question. And then there was a question, are we going to receive talk time to be calling people and to track people? I think that's a question. And then will GBV
So
service
Dr.
be
Jambo, I can be, maybe once you highlight one question, then I respond to that.
Okay, please go ahead.
So there are plans in the work which we have been doing the past 2 weeks plus has been centered around making sure that the services which are provided, they are provided in a continuous way. We are aware that HR is a key aspect. We understand that we currently have, 11,350 staff employed by PEPFAR support, and some of those are sitting with partners, and some of those are sitting in government under quads, and we have budgeted how much the cost is to keep this human resource. This is the work which we finalized yesterday. People have been working throughout the night. Can imagine having meetings with Director Finance, Director Planning. All the directors have been actively involved in this aspect to make sure that we safeguard also those HR aspects which are key for us to provide support. So it does not just limit to those who are working under government and supported by PEPFAR. It includes even those that are in partner organizations. Now, that does not mean that government will pick up all those wage bills should the PEPFAR go. It has to be done in a gradual manner, and you have to work at mechanisms on how this can be absorbed with minimal service interruption. What was the next question, Doctor? Over talk time? So the way that we provide services will also need to be modified. Government want to be in the interim, be able to give airtime to call people who are not reporting for services. But there are mechanisms of how can we use the community structures to make sure that we have tracking of participants. And I know if we have withdrawal of funding from the donors, either Global Fund or PEPFAR, there will be huge implications, and the way we provide services will be different. And that's why the minimum package, which we are going to speak to with you possibly within 2 weeks, is going to address all these issues. Dr. Kozia?
Thank you so much, Prof. There is a comment here regarding any information about the USAID supported provinces. You did mention it, but I think there's just need for clarification on that one.
Yeah, so I won't be able to speak to the waiver really, because right now there are those processes which are going on in the US around what is allowed, what is not allowed, and the restrictions. But also just in principle, and say what does government put in place after the 90 days. So this is the plan which I was trying to highlight to, which we just finalized. And I think that the other aspects have been finalized possibly this afternoon. We have costed the whole HIV service delivery, including HR. And we are presenting those to make sure that we have minimal interruption after 90 days, should there be total withdrawal, which I don't think may happen, but it's possible. We are not in control of this fund. So as government, we are making sure that we have the budget lines ready and engaging the permanent secretaries, engaging the finance, the ministers, and cabinet has also been quite supportive in trying to make sure that we have minimal interruption of services. So I'm sure 90 days, should we come to the worst case scenario, some of those interventions will kick in. But of course, it may not be the same way we deliver HIV service delivery. Mentors, yes, mentors has been an issue. I know some regions, especially on the northern side, mentors are not where we are given letters of termination. We cannot comment on engagements which were done by the partner, but the whole principle is for mentorship. It is very key, and we'll continue to provide mentorship in a government setting. And also we try to build a lot of capacity through ECHO and telemedicine as well. And all those mentors are part of the HR aspect, which we did look at. But the job modification, if moved under government, may be different. We need to look at direct service delivery. How can a mentor be involved in direct service delivery, impacting the client and also impacting the mentee?
Thank you so much, Prof. There is a question here seeking clarification on withdrawal ARVs in private facilities.
So that is a consideration which is on the table for private facilities to take up the participants or the recipients of care rather, who are under them, instead of where we provide ARV services. Remember, we have people that are able to manage buying these drugs, that are able to have a viral load paid for. So we need to look at how best can they take care of their health so that government and partners, they concentrate on the others who are able to manage that. So we'll be encouraging private sectors to pick up that budget line for certain participants.
All right. Thank you very much. I've seen a hand
to come to a public sector.
All right. Thank you, Prof. Mr. Owen Mulenga, you can unmute yourself and ask your question.
Thank you very much, Doc. Thank you very much, Prof, for the presentation. Thank you very much. Now, my question is, Prof, the future is very worrying, because I'm seeing if after 90 days the PEPFAR won't come back, and America as it is, it will also affect the global fund. Where do we put us people in HIV? Why shouldn't we worry? That's the first question. And the second question is, we had a problem with the TAFED even before the American policy change. I don't know after that, what are you going to tell us about the TAFED? Because most of our constituents are complaining that they are being removed from TAFED back to TOD, back to TAFED, back to just go back and forth. And with the coming of this, they are more concerned and worried. They are asking questions day and night. Where do we stand as things are? Thank you very much.
Thank you, Owen. One thing which we can assure you is commitment to making sure that the ARV is available for everyone who needs to be on treatment. That budget line, I can assure you, will be safeguarded. The issue around TAFED availability had nothing to do with lack of funds. It had everything to do with the manufacturer not able to meet some of the issues they had with FDA. And then we could not receive drugs from that plant because it was an FDA regulatory issue with the manufacturer. And this was affected the globe. Now, if you ask me, should we be worried if there was no PEPFAR support? Yes, we would be worried if there's no PEPFAR support. Why would we be worried? Globally, PEPFAR is supporting a lot of work. For Zambia, when you look at the Global Fund and also PEPFAR, they are contributing to about 90% of our HIV service delivery. So yes, we need to worry because a lot of aspects may be affected and will be affected if we don't have these donor funds. But we have to be realistic. Should that come, then we have to have other mechanisms kick in. How can government provide that service at a very low cost? We have to relook at all those areas, and those are areas which we are looking at. But I can assure you, ARVs will be available even without that support. That's a priority, and government is looking at making sure that their mechanisms are available. And this local manufacturing, it's good that Zambia has advanced in that area. It may ease the way that we look at the supply chain better. Thank you.
Thank you, Prof, for that very exhaustive response. So there are some further questions.
There's a question which I've seen here, Dr. Ziambo, sorry. Over USAID, when are they resuming work? I can say we had an engagement. The US government met us, led by the ambassador himself, and we did appreciate with the PEPFAR team, USAID, CDC, DOD. And in that conversation, it was a very frank conversation, and we are told that our services were opening up. USAID partners will also open up. Possibly within 2 weeks, we should be able to see USAID partners as well come in. The issue with them is that because it takes time for them to, again, to redeploy staff back. The staff to IPs again over the weekend. I have a sense that within the next 2 weeks, we should have services running smoothly, even in the USAID supported areas. Thank you.
Thank you so much. You still have a few moments with us, Prof?
Yes, I have about 5 more minutes.
Okay. So I think I'm just trying to check on some of the questions that the team has. Okay, I think most of the questions have been responded to. And I think this one was how are we going to continue with capacity building of facility staff when there's a waiver is not supporting mentorship?
Sorry, Dr. Ziambo, I didn't hear you.
Or it's about supporting the capacity building activities, trainings, and all those things.
What is the question around capacity building?
So I think there's a question here they're asking, how are we going to continue with capacity building activities?
Yeah, I think I focus differently. We have to provide capacity building differently. And that's why the platforms like ECHO are very key, where there will be interactions for mentorship, one-to-one mentorship, that will be available. But we are trying to see how we can heavily invest in telemedicine and also the ECHO platform for capacity building. I think times for large conferences, large meetings should be over. I think that we'll be able to go through on that. We have to change the way we program and the way we do services. Dr. Mtimushi, over the inmates, again, these are areas where we need to know which IP was responsible. These are pieces which government is taking up, and we take this seriously. The inmates, those on ART and TB, they should be able to be provided with a similar service which receiving. We can engage, I think I will have a call with you on how best we can move on. In terms of the human resource, when is GRZ planning to put people on the permanent? This is a big issue. Plans are underway. I cannot assure you when and how many people are going to be put, but at least there are plans and the costing has been done.
No, thank you very much, Prof. I think most of the questions have been answered. There's just one more here about the CBVs and SIS are no longer on site in provision of HIV services. There is so much workload basically on the counselors under GRZ who are multitasking in terms of contact tracing and HIV testing at the same time. There's a question here, any views on that?
Yes, we realize that you're taking up a lot of work, those who are working. And we are currently looking at how can the Global Fund help support the CDB budget line, but also in the long term, looking at which other ministry areas can we leverage on around the CBVs for them to help support the services. We have an estimate of about 6,000 CBVs or so across the country. So that is a huge line. We hope that we can have immediate mitigation measures available through the Global Fund and other areas like from community development who can pick up that line. We also have to look at can we have the CDF chip in as well? So those are areas being looked at, but it's not that the solution will be found today. For dream centers, yes, dream centers should they not operate? Again, these are under PEP5. Should they not operate the way they've been operating? We have considered how we can move these to other community areas, not just the youth-friendly services to be provided there, but anyone who needs HIV testing, basic prevention services, but to be picked up with the mother facility overseeing that.
Thank you so much, Prof. Kelvin Shala, you can unmute and ask your question.
Thank you very much, Doc. Thank you very much for the presentation, Prof. I think the message is very clear. Mine is just to find out if at all government has put in plan or considerations in terms of employing counselors like from MOH, as well as maybe some specific data personnel. I say this because of what we have gone through just for these few days or weeks. We have not been with the partners because, for example, if I speak for Chinsali, to be specific, in Mchinga province, we only have one counselor under MOH, the professional counselor who is seated at Chinsali District Hospital. So much of the community work and even the testing at the facility, it is really something which is difficult. So we're just working with the staff who actually around. So this could be an eye-opener that maybe MOH may consider to support this department of HTS in terms of employing maybe counselors so that we can be safe also in that regard than depending entirely on the partners. I submit.
Yes, you are right. And that's why I'm sure Dr. Koza will go now into the tool. We need that information. We need from the provinces, each side, to tell us what is happening, what is not happening, HR issues, so that we can know where we need to refocus our support, and where if GRZ or Global Fund has to come in, we do that urgently. So the next thing which will happen after this is going looking at that too, so that we can provide that information which is cardinal for planning purposes. There was a call, Dr. Ziambo, here over the KPs, that something about the KPs. Yeah, question on KPs from Nalukui that needs clarity. I don't know what the question was all about. I don't know, maybe Nalukui.
The question was on programming. They were just interested in knowing whether KP programming will continue now or beyond 90 days.
Under PEPFAR?
If the government will continue providing those services.
So government will provide all prevention services, all treatment services to all populations, regardless of risk category. So that is the message which should be there. So if it's a female sex worker who needs prevention, prevention will be given. If it's any other person who needs prevention, prevention will be given to everyone. Treatment will be given to everyone. Now, how it is done, let's say for those under PEPFAR, right now what I understand is in this state, services should be provided to all, including KPs, until we have any new information from the court cases, what is happening. So to me, the dreams, the KP, the wellness centers should be able to open up, but that information, if you're supported by a PEPFAR, that information should come from there. But right now, general guidance is government will provide prevention, treatment services to everyone, every Zambian who needs that service, regardless of a risk category.
This is well appreciated, Prof. I think one more, just before we release you so that we can transition to the other presentation. There's a question by Sydney Chilala. You can unmute and ask a question. Thank you.
Okay, thank you for the opportunity. This is Chilala Sydney from Masha Hospital. So mine is a question on the human resource. It's like these people had an idea of what was going to happen at some point. So there were people that were taken to school, sponsored by the same NGOs, so that they could be part of ART programs in facilities and districts. But up to now, some are still misplaced. I'm talking about HIV nurse practitioners who were trained, I think, countrywide. So they're still misplaced. Some are in places where there's only a TX score of 100, maybe 50. Are there any immediate plans of getting these people?
Not to cut you short. Not to cut you short, that is an important point, and we are looking at which HR needs to be where. So this is a time where we need HNPs to be where they should be able to provide HIV services to the people where they need. So it's a good point, and that's why we need that feedback on which services are happening where. Stock status of Kable, we have enough stock. I need to emphasize that. And with that, Dr. Kozia and the team, I would say thank you so much for allowing me to speak and engage with you. We are committed to providing HIV services, even in difficult circumstances. Just know that we appreciate all the work that you've been doing. Thank you so much. Over to you, Dr. Ziambo.
Thank you very much, Professor Mulenga, Director of Infectious Diseases. I think this has been a timely message and information to our community who have been looking forward to understanding what government's position is and the guidance on how we're going to proceed. We may not have answered all the questions, and as we go on, I'm very confident that things will be clarified, things will become clear as we navigate this dusty situation. And just to add to that, the memo has been released, and I think it has been, the PS has directed that there should be redeployment of staff in different places to help mitigate this current challenge that we're having. So we are going to move on to our next presentation. I've seen that there are comments about smart care. Indeed, smart care also in terms of staff as well as the apparatus. This has been costed, and we are actually going to present the costing to the permanent secretary and to the hierarchy for its possible resource and support. So now we're moving on to the next presentation where Mr. Liswaniso will be sharing some monitoring too. But before we do that, I'm going to ask Dr. Sivile, our ART advisor, to be able to just give a background to this and then hand over to Mr. Liswaniso. Dr. Sivile.
Thank you, Dr. Ziambo. Can you hear me?
Loud and clear, thank you.
Oh, thank you, and thank you, Network, for joining us. I think just to summarize what Prof was saying, so we have these 3 months where our understanding at the moment is that the stop work order has been rescinded. The CDC supported organizations, I think, should be back to work this week, and we expect the same to happen for USAID. We do not know what will happen after 90 days, and therefore we are preparing to sustain the services with other means. So those are the preparations that Professor was talking about. I've seen a lot of questions on data, so including data if need be that PEPFAR drops off in terms of support after 90 days. Government is prepared to take on some of the data clicks. So those are the plans, but like Professor has said, we cannot commit, but it's very important to have that roadmap, that this is where we are. We expect in the next 3 months, things to be the same as they were before the stop work order, because they've been rescinded, but we do not know what will happen after 90 days. And the preparation is to have that minimum package, which will probably reprogram a lot of things, but the desire is for everything to continue as planned. At the moment, we know there's some form of disruption in facilities. A lot of things have been aired by a number of you, and we know that it will take a lot of challenges for us to get back to where we used to be. And therefore, because of that, we have released some data collection tools which will be at facility level, because we want this data from facility level, and it should be entered by individuals in ART at the facility. Mr. Liswaniso is going to come and explain why this is important. We want this almost near live data every week. And the usefulness of this data is, 1, to understand what is obtaining right now, and 2, to have an understanding of how we are coming back online, or coming back to where we used to be, and where the challenges would be, what we need to institute. Without taking much of your time, I would ask Mr. Liswaniso if he's ready to give us that presentation. Mr. Liswaniso, over to you.
Thank you very much, Chair, and good afternoon, team. So the presentation will be handled by the team. There will be my colleague Chisenga, who will handle the data capturing on DHIS2, and then the other colleague, Shimba Mwasa, will also come in to look at the data capturing using the Kobo Collect. So we believe that data capturing already started as people were populating on Google Sheet, but now efforts have been made to have it in a more robust, structured way, so that we'll be able to capture data, follow up on where there are hitches in data submissions, and for us to be able to have a good visibility from the same data that is being presented. So the presentations will cover the two modalities as mentioned. the data capture in DHIS2 and Kobo Collect. So I also wouldn't want to take much of time. Chisenga, you can just be on standby. We can have the slide decks for DHIS2 on. Kote, you can proceed to display our slide deck. While we are waiting for the slides to come on, DHIS2 is one of the systems that we have been using for the ministry for a number of things, with two modalities of.
Hi, Liswaniso, we kindly ask that you share from your end.
Okay.
Hi, Liswaniso, are you able to hear me?
Okay. Yes, noted. We'll
Okay,
we'll share from this end.
Thank you so much.
So as we wait for the slides to come on, I was mentioning to say DHIS2 is one system that we're using at all facilities, mainly for aggregate reporting, where our facilities are able to pushing the monthly reports in the aggregate format. We have also used the same DHIS2 to even capture horizontal data for COVID. So this modality that my colleague will run through is looking at the aggregate workflow. Chisenga, you can take it up.
Thank you, Liswaniso and Chair. I kindly confirm I'm audible.
Yes, you are audible and the slides are visible.
Okay, thanks once more. So mine is a quick one. It's just an orientation on how the data collection process is to be done. So this is the outline of my presentation. So we're going to look at how to navigate to the DHIS2 instance, the login process, and then selection of the app that we're going to use to collect this data, as well as how to set up the appropriate reporting profile for the data collection. And then we'll complete the form and submit. So what you're seeing there is the URL that routes us to the application that we're going to use, the platform that we're going to use. So you just type this URL into your browser, and then it's going to give you this landing page where you need to supply your username and password for you to sign into the platform, to log into the platform. So the credentials will be provided as per advisement, I think through the chair. So once you sign in, this will be the landing page after you're authenticated. So if you check on the top right corner, just between the part that says online and CS here, there's a menu icon. So when you click there, you are going to get a drop down of the applications that you are going to have access to based on the roles that will be configured on your user profile. So Here, you'll be required to go to data entry. So that is the icon that is highlighted with a red border. So when you click there, it will lead you to this page where you, on the left side, you have an organizational tree with Ministry of Health as the highest in the hierarchy there. So just above where it says Ministry of Health, there's a green button that you can use to search for your facility or the facility for which you are entering or collecting this data. So you can search there, and then it's going to just cascade down the whole organization unit tree. You have to click. So in this case, we're looking for Liteta District Hospital. And then once we click, we select Liteta District Hospital. The next thing we have to do is to select the data set. So the data set here is called Continuity of HIV Services. I think based on the account that will configure for you, it should be the only service that will be available. And then after that, you have to select the period for which you're reporting. So since these are weekly reports, so weeks are already calculated for you. You just have to select the week for which you are reporting that data. Once you select the week, the form will load. So on top of the form, we have instructions. So these instructions will apply to the question that asks about months of stock. So what we're showing here is just the section for HIV testing services. We could not show the whole form, otherwise it wouldn't be readable, considering the size of the slide. So what the instructions are telling us here are that if you have 1 week of stock, you enter it as 0.25. For 2 weeks of stock, that will be 0.5. For 3 weeks, 0.75. And then 1, 2, 3, and so on for the actual absolute number of months. Okay, so for now, we're just showing the HIV tests, the HTS services section, but there are about 10 other sections that are interrogating the same similar questions actually about each service area. So once you fill in the information, this is the bottom of the form. As you can see, there are other service areas that we are collecting data about. For example, there's smart care data entry, there's VMMC. In between the top and this part, there's things to do with cervical cancer screening and the like. So once you are done with the data entry, all you have to do is click the complete button, and that is it. This is where the presentation ends. So in the interest of making the tool very user-friendly and simple to learn, that is as easy as it gets. Thank you very much. Mr. Liswaniso, over to you.
Thank you, Chisenga. And those with questions, just take note, you can write them down. We'll have them at the end. We can quickly proceed to the other segment where we look at how we can capture the information using a Kobo Collect. Shimba, over to you.
Please confirm, Liswaniso, if the presentation is visible and am I audible?
Yes, you are loud and clear. The slides are visible. You can proceed.
Okay, thank you so very much. So this is basically also the outline of the presentation. It's quite similar to what Chisenga just presented, navigation of the Kobo toolbox. Particularly, this is on the MOH instance, then also logging in and the filling in of the form. So I'll also not bore you so much to go through exactly what Chisenga went through, because the indicators that are in COBO and the one in DHIS2, they have been mapped and named in the same manner. So it's just the two instances that are different that we are using. So the URL also for COBO, this is the way it is being presented. You simply have to click on the link that may be shared either on WhatsApp or maybe to your email. But it's just an issue of clicking. There's no any other details that you need or credentials that will be created for you to enter. It's simply clicking on the link and you are able to go to the interface. So this is just a display of an example of how a link may be sent to your WhatsApp, just in case it's sent on WhatsApp rather than on an email. So immediately you open the COBO, on that link, there will be a provision for you to select the month. So once you select the month, if it's February, it will bring the weeks that are in February or that are in March. Excuse me. So this is just an example of January being selected, and the weeks precisely that are attached to January and the dates. So you may be able just to select from the 4 options that are provided in this case. So once you select the week as well, the next part it moves you to is to select the province that you are in, and you can also select the district precisely that you are in. Then it will lead you to only facilities that are in that district. So in this case, Chipata district is selected. And then the list of facilities that are under Chipata are the ones that are coming down. So this these facilities that have been loaded in the tool as exactly as they are in the MOH instance of DHIS2, the very one that Chisenga just presented. We just got the very facilities and the way they are named so that it is not difficult for you to recognize the facility, just in case you end up using the COBO toolbox, maybe because of no internet at your facility to allow you to use the DHIS2. So these are the program areas. From what Chisenga presented, you only focused on the first highlighted one, HTS services. So these are the specific program areas, and they all have the same questions as the ones Chisenga highlighted. So I will also just comment a few comments on the HTS so that you understand how the COBO flows, but the parameters, the understanding, they are all similar. So for HTS, months of stock of rapid determine HIV test, this is one of the first indicators for HTS. So there's an instruction also at the bottom there, helping us to see that sometimes you may have not a full month of stock, like Senga mentioned, you may have only for a week. So a week is equivalent to 0.25 months of stock, then 2 weeks, 0.5, then 0.75 is equivalent to 3 weeks. Then if you indicate a 1, then it implies that it's 1 month of stock. So that is a guide you can also use to follow. The next indicator is looking at staff, including the CBVs before January 31st. So in short, by January 31st, how many staffs were at the facility, including CBVs, supporting HTS? Then also now you look at the current staff after January 31st. What is the current status in terms of HR, including CBVs? The next indicator is looking, do you offer the same HIV services at this facility? Then also it continues with ART services in the same manner, including pediatrics. It's looking at the status for the stock status, also for ARVs for adults, for pediatrics, and also it also asks questions about CBVs in the HR category, how many were there, including the CBVs and all other facility staff before January 31st. So the tool continues, even asking about viral load. If the facility is still providing this service, like Prof mentioned, there are specific indicators just targeting to understand if the service has continued or maybe the service is no longer there, such as courier also is one of the indicators being captured in both in DHIS2 and in this COBO toolbox. PrEP also is also being captured. The same questions asked. Is PrEP also provided? It's a yes or no answer, and also the number of staff that were attached to that department. EID, the same manner as well. We'll look at months of stock for ARVs for postnatal prophylaxis as well as the DBS. We look at also CBVs as well as the current status and also whether the service is being provided or not being provided. We want to see responses to such questions also. The same with the cervical cancer. The same questions are also being asked as well as the commodity availability at the facility. VMMC also, similar questions, commodity availability, HR, and if the service is still being provided. Smart Care, also looking at the functionality of Smart Care, number of staff supporting data entry, also before January 31st and after January 31st in terms of the current situation. The next session is looking at nutrition. This is just a one question under nutrition. It's either yes or no, the service is being provided. When you come to community ART, also it's also looking at just yes or no, whether the test is being provided, also distribution if it is being provided, and also looking at the defaulter tracing if it is being conducted. Last but not the least question is a comment that you need to indicate. What are the challenges that you are facing currently? You need to provide a comment on that. Then finally, the tool has got a provision for you to save in draft mode, but this is now when you're still online, it will still save on that web page, and also a provision for you to submit that report immediately once you are done, as long as you're connected to your network. Thank you so much. I think I'll hand over to Liswaniso to continue from here. Thank you.
Thank you, Tim. Thank you, Chisenga and Shimba, for that one. I think at this point in time, now we can open up for comments and questions so that we clarify. Tim, do we have any questions? Okay, there is a hand from Jamie. Jamie, you can go first.
Unmute. Hello?
Hello?
Yes, you are
Okay.
audible.
Okay, thank you, Liswaniso, and the colleagues for the presentations that you've made. So one question for me. Who is going to be responsible for capturing and submitting this data at facility level? I'm asking because most of these facilities are supported by IPs, and the data management aspect of the service provision mostly is done by, let's say, SI assistants. And as things are, I think not all IPs have resumed, their presence in these facilities. So is it going to be done by the in-charges, the MOH in-charges? And if that's the case, have we provided similar orientation to them so that they submit data as expected? And then apart from that, how often is this data or information going to be needed by HQ MOH? Over to you. Thank you.
Okay, thank you for that question. We can also take the other question by the one connected as Copperbelt PHO.
Thank you very much. Quite a great presentation. Just to inquire, are we going to give the provinces the right to view so that in the end corrective interventions are made when facilities are meeting? Over. Was I audible?
Yes, you are audible. when we can also, I think, take the other two. Taurai, you can go first.
Okay, thank you so much. Are you able to get me?
Yes, you are audible. You can proceed with your submission.
Hello, are you able to get me?
We can get you. Please proceed.
Oh, okay. Thank you. Thank you so much for the presentation, Liswaniso and Nshimba. My main focus on Kobo2Box software that you are using to capture the data in these facilities. So my understanding is that the Kobo2Box has got limitation in terms of the number of submissions that we may upload on the server. So for example, if you're using a free version, you need to submit about 5,000 number of responses in a month. So my question is, are you using a paid version or it's a free version? Or probably that will be covered depending on the number of facilities that you are capturing from. Thank you.
Okay, then we can take the last one from Chimwemwe.
Good afternoon. I hope I'm audible.
Yes, you are.
Okay. Thank you very much for the presentations made today. So just have a few, I don't know if it's questions or comments. I'm not sure with the tool that has been made, if we're able to make any additions or further suggestions, but I was just thinking around on the aspect of HIV exposed infants and the services being provided. I noted on the prophylaxis, it gives ARV prophylaxis months of stock. So just thinking, because they are on like the 3 drugs, AZT, 3TC, NVP, would it be better if we could separate the AZT, 3TC, how many months of stock, NVP, how many months of stock, because they don't necessarily come together. Then my other concern also on the number of staff, I think so this is on all the different categories. Is it possible to break down the staff in terms of how many are actually CBVs and how many are maybe nurses or whatever other cadres, so that it's clear to see, to be clear to know which are the staff who are probably, let's say, full MOH, who are the staff who are partner employed, just to have a clear picture of what the gap may be, if, God forbid that the PEPFAR funding is removed. Yeah, those were some of my comments. And then as well as on the HIV exposed infants again, the question says, is the service being provided? Yes or no? It would be nice to know also, because MCH, once a woman is pregnant and breastfeeding, they have their ART services in MCH. Is it possible to know if this woman is receiving a service in MCH or in ART? So that if they're moving to ART, it would be easy to know, is it an issue of the skills in MCH we need to be improved? Or is there something that is causing them not to have services provided in the MCH where they're supposed to be provided? I hope those are clear enough. We can get a few comments on that. Thank you.
Okay, thank you very much for those questions, for that first segment. I think maybe to kickstart the response, let me invite Dr. Kozia. Maybe you can help us answer the first one, which says, who is expected to be responsible for capturing the data, maybe before our team comes in?
Thank you, Liswaniso. Dr. Koja is pointing at me to answer. Can you hear me?
Yes, we can, Doc.
Yeah. So I think this is an emergency scenario, so we can't have plans as usual. So what we want is facility information. As you can see, the details that are there are not clinical related details that we want. We are not looking for how many people have been tested and so on and so forth. So really the person who is in charge who's responsible for this too is the facility in charge. And that can be delegated to the ART in charge because most of those services are within their domain, and it depends with how big the facility is. You know, they differ. And who does the work? Obviously, we know that each facility has the data crate or a similar cadre, even under government, where they can do the work, where that person is not available in very, very small health posts. Some of them, we know they've got like 25 or so on. We actually expect the ART in charge or the in charge of the facility to fill in the details. So access will be given to the DHIS2 for these individuals, and those who have the access will be extended. I'm sure the IT colleagues will give more details, and the Kobo Collect as well. We will share the link how you can have access to that. I'll go ahead and maybe speak to the last question. What was the last question again, Liswaniso? So that I answered. Hello?
It was to do with, the way I understood it was to do with the integration of services.
No. It was on data points. Sorry. Yes. So from Chimwemwe, yeah. So we would have loved to have a lot of data points. Yeah, but we know that we are stretched even at facility level. We don't want to take a lot of time. So you can see this is a very simple tool. So hence we've summarized. We would have loved to know where EID, what drugs are there and so on and so forth. So for commodities, the EID, prophylaxis commodities, you pick the list, the one with the least month of stock. You have AZT3TC and NVP. If the one that has got the least month of stock, which is 2, is NVP, and AZT has got 3TC has 5, you give us the 2. Similarly, on those second line and first line and so on. First line, you have TAFED and TLD. There, I would really like to know the TLD because that's the bulk. That's good. We have some challenges with TAFED, as was pointed out earlier. And for cadres, would have loved to know how many CBVs. There's a part for comment at the end. You can say if you feel your facility is really stretched with CBVs, you can mention, we have 1 CBVs. But our assumption is for testing, for instance, we think those are CBVs, and for ART services, we presume that those are clinicians who could be either clinical officers or nurses who typically work in those service points. And for lab, typically, we presume that those are lab scientists or some sort. Yeah. We would have loved to make it elaborate, but that would have meant a very comprehensive tool, which would take a lot of time.
Okay, thank you, Dr. Seville. And then to answer the other parts now, there was a question just trying to find out whether we are using a free or a paid one, since it brings about the limitation. The platform that we are using is a paid one, so we don't see ourselves getting into that limitation. Then with regards to provinces or the subnationals being able to view the data, definitely that is the whole purpose. Starting from facility level, when you're pushing data from DHIS2, you'll be able to view it at facility level. Officers at district level will be able to see their facility performance. The staff at provincial level will be able to see the overall district performance. So the view rights will definitely be given so that you yourself as managers at those levels will already be able to begin to maybe scrutinize the data, looking at the data quality and make meaningful decisions also from it. It's not just for central level. You'll also be able to use that, the data that will be captured. So 2 modalities mentioned, DHIS2, So DHIS2 does require internet for you to transact, but the Kobo Collect will be able to offer us the offline mode. So for DHIS2, we also get an impression from you, as in those who may already have credentials that we may have to extend to be able to capture information. But for Kobo, the link that is already in the presentation, once you click on it, you are able to access the platform and be able to populate the data for the respective week. It's a weekly report, so at the end of each week, you are expected to report the status for that particular week. And you may have already noticed that for each sections, there are questions that are talking about what was the status at the close of January when those pronouncements were asked. Once we collect clear information on what that baseline information was, that segment of questions will no longer be appearing because we would have already established the baseline data. Only weekly status questions will be appearing. So that is part of the extra clarification on the data that we are be capturing. So we can now get another set of questions. I see there's one, we have one hand. Damian, you can make your submission first, then, yeah, Damian, then we get to Livingstone DHO.
Okay, good afternoon. It's a very good presentation. Am I audible?
Yeah, loud and clear, please proceed.
Okay, so on the HR part, I think for ART departments, I think the numbers were put, for example, if you go to PEPFAR, how many were providing that, sorry, PrEP, and then how many before, and then how many after. Because what I understand is that usually in ART, the same people who provide from HTS until medication is dispensed should be the same team. So if you are repeating for each commodity, is that going to cause a double counting?
Okay, question noted. We move to Livingstone.
Thank you so much. Good afternoon. Yeah, so I just wanted to also add the voice. This is Dr. Sakuka. Yeah, so I want to suggest that even as we are discussing it, and I think we've gotten the guidance, if we could look at the importance of this information, if we could communicate also through the PhDs, which would trickle down to the DHDs and also the SMSs. It could be via email or just the established WhatsApp groups, just to make sure that all the facilities and the expected hospitals take up this information and start running with the reports just for consistency. Yeah, I understand some of the facilities respond differently, but I think as district will be on the ground to make sure that the reporting is being done. But I feel like it will help also if there's just that formal communication coming through MOH, PHOs, and maybe central hospitals or UTHs just for consistency in terms of reporting. I submit.
Thank you. That question is noted. Okay, we can take the other one now from Nathan Sinyangwe.
Okay, thank you very much. Good afternoon, everyone. A great presentation indeed. Mine was, as Prof says, we received such a similar tool for an assessment, but the one that was shared on mail was from HTS team from MOH. No, though not so comprehensive, but similar measures. Though in terms of HR, it was more of speaking to CBVs. I wanted to find out, is this what has been presented and shared? Is this now a consolidated tool, or will still be receiving other assessment tools from MOH. I was thinking maybe we end up having duplications where this program requests for this other program may request for this. So is this a comprehensive consolidated tool that captures everything across the whole HIV continuum of care? Thank you.
Okay, thank you very much for those three questions. I don't know whether it's Dr. Seville or Dr. Kozia will respond to this. The update on the communication with the subnationals, the PMOs, PhDs to the in-charges.
Sorry, Chair, perhaps I could come in. This is Luasi from MOH, HTS program. So just to respond to Mr. Nathan's question, so perhaps we could go with what has been shared now, because this one kind of more or less aggregates everything. So we could go with what has been shared here. Thank you.
Okay, that one is noted.
Yeah, so the first one on duplication, yes, so there is a risk of duplicating same individuals, but the interest of this tool is continuity of service. That's the purpose. We did collect data already on how many HR we have at facility and their cadre and so on. So that data we have, and that's the one Professor Mulenga was referring to. We've costed it, and that's the one we've already submitted. We are in the process of submitting to cabinet in terms of what we, to be replaced and so on, and that work. That for that purpose, to say what is the position of this person and so on. So that baseline has already been done with different tools. I'm sure facilities or provinces, you are aware that you did submit that information. Here, the interest is the services going on, and we want to monitor this evolution of services coming back online as time progresses. Because the most important, command that will be given is we need to continue the services of ART as they were before the stop work order. We need to continue that, and time will come when we give a revised work minimum package of services, then that will be the standard that we continue with. So this is the way we are doing things. Yeah. Concerning communication, I think that is noted, and PHOs were already communicated to last week. I can see some of them are on the platform already. So, for instance, the HIV TB focal point person are aware of this work. Yeah, but what we are asking is those of us who are on this call, we pass on the message, and if need be, write memos, whatever you request us to do, we'll be able to do that even to PhDs and SMSs. But we'll check that and improve on those communications. The issue of, is this the last tool or consolidated tool that we are requesting for? The answer is no, Nathan. We'll continue asking for tools, different data sets in this period for different purposes. Yeah. For instance, we might ask the type of drugs or whatever, depending on need arises. But like I explained, the purpose of this is continuity of services, to track that these services are they being provided and what is needed to provide them. So it's got a specific to the other data requests and so on. Others will continue. There are people who will be doing research and so on. You see a lot of data requests over this issue. Yeah, and as you very much know, data is requested for particular purposes, and then the data points might be different, might vary from one request to another. Yeah. So this is not the final.
Then, Dr. Severi, maybe before we take more calls, maybe you can also gaze through the chats and see which questions we can take.
Okay, we'll try and do that with Dr. Zambo. Thank you. Dr. Zambo, any addition? Dr.
I think so far I think the responses have been adequate. We'll try and respond to the questions there.
Okay, so we can take the question from, I can't see properly now. Damiano, is that the old hand or you have a new submission? Okay.
It's a new submission.
Okay. You
Yeah,
can proceed.
so thank you so much. So for some facilities, we were using eLabs for VL records. I think you're using some gadgets provided for by other partners. So given that there was that stop order, we haven't been able to collect or receive those results. I don't know how this can be done so that people are able to update and get proper results for the clients being cared. Thank you.
Okay. Do we have more questions? Do we have any more questions? I'm still checking here for hands or questions. I've just put in the chat the global credentials for you to access the data set on the link that has been set. You'll find it in the chat. As we get to know more of the people who will be entering the data, more individualized user credentials will be created. But we do not want to create or leave room for excuse to say people do not have credentials. So the credentials, you find them in the chat, which you can use to populate the weekly report. So it is expected that the week is ending, the heavy business work ends on Friday, that by the close of Friday, people would have compiled and made the submission of the weekly report, which gives time for people to do a bit of some analysis over the weekend and be able to report to other offices by Monday. So the reports are expected to be submitted by the close of Friday.
Sorry, Liswaniso.
Yes, Doc.
Yeah. No, I don't know if you've already shared those credentials. I think let's allow the ART coordinating teams at the province and district decide which people in the facilities are going to have those credentials and upload, so that there's a bit of order. I submit.
Okay. Okay, we have a hand from Sydney.
Okay, thank you for the opportunity. Mine is a short one because I've heard in the meeting that there was an exercise of submitting qualifications or the human resource activity that was happening. For those that missed, is there any other chance that they could also be captured? Because I could be one of the people affected.
Okay, so that question is directed to who exactly?
Yeah, I can pick that and clarify. I think, Sydney, what we mean is these are aggregate data, not individuals applying for work. So what we wanted to know is, for instance, in trauma districts, we'll ask how those people working in ART, how many are nurses? So how many CBVs do you have in the district? How many lab individuals, how many data clerks, CRs, and SIs individuals, that sort of. So it's aggregate individuals. So we are using that information to ask the central government to say, okay, can we, if PEPFAR goes out, we need so many nurses. Can we have positions? We need so many data people, and we hope to lobby maybe so many community health workers, for instance. So these are aggregate data, not individual sending qualifications. I hope I'm clear.
Thank you.
Liswaniso, perhaps we should be wrapping up. I don't know if there's any other guidance to give. I think to everyone, this what we are requesting for in this exercise is that leadership from provincial and district level and facility level. We need your buy-in. Obviously, we are in special scenarios here. We all know that we knew that one day we'll have challenges with funding, but we didn't think that will happen in this manner. Yeah, so we are asking for your buy-in. And again, we would like to give our sincere gratitude to our provincial and district teams for continuing the work. We are aware that almost all facilities have continued at the very least to dispense our ARVs. So thank you very much for your effort, your wisdom, and your innovations that you've put in the districts and facilities. Yeah, I've seen some people who worked very well, like our colleague, Mr. Matafwali from Muchinga. Thank you, sir, for the work that you are doing. Yeah, so I think that's our closing remarks from us, the program. So we'll share the package, the minimum package, in due time, like Prof has said, maybe within 2 weeks or so. So you'll see a lot of activities on this ECHO platform with regards to how we proceed in this our sustainability agenda. We did write our sustainability roadmap, which was launched by the minister last December. That's how we can just sustain our HIV program. Dr.
Thank
Zambo,
you.
over to you.
Thank you very much, team. It's been a great session, very informative, and a lot of questions asked. And unfortunately, some questions may not have been answered satisfactorily. But like I said, this is an evolving situation. We'll try and be very adaptive as things unfold. And thank you very much for joining in, everybody, for your participations, for your questions, and for your engagement. Thank you so much, Mr. Liswaniso and team. We do appreciate for your intervention in helping us have a more automated system to help us collect this monitoring data. And we are ever so grateful to the leadership of the PS, Permanent Secretary, in the way he has guided with the memo. And I think that forms a framework within which we are going to operate our services. We still have a lot of work ahead of us, but we'll do it together and hopefully we can continue to provide services to the Zambian people who need it. So that being said, we'll continue to provide capacity building more than ever on this platform, and because of the way we have to change the way we do things. So please hold on tightly to this link. We'll continue to come on this platform and share innovations, new way of doing things, and how to manage recipient of care. That being said, we look forward to seeing you again. Bye for now.
Thank you.